My name is Mary-Louise Greer. I'm a pediatric radiologist from the Hospital for Sick Children in Toronto, Canada. This paper is entitled, Can MR enterography screen for perianal disease in pediatric inflammatory bowel disease? The background for this is that in pediatric Crohn's disease, perianal disease is present in approximately 10% of patients within 1 month of the initial diagnosis, occurring in up to 21% at any time in disease course. Magnetic resonance enterography is used to evaluate small bowel involvement in pediatric inflammatory bowel disease, while pelvic MRI, optimized for the perianal region, is the gold standard for detecting perianal disease. With increased use of MR enterography, perianal disease is more frequently recognized, which in our pediatric IBD patients initially prompted pelvic MRI for confirmation. This is because MR enterography and pelvic MRI are not routinely performed at the same time in children with IBD due to issues of procedure length and patient compliance. This prompted the following hypothesis. As a standard MR enterography protocol field of view includes the perianal region, MR enterography may be sufficient to screen for perianal disease, excluding perianal disease if clinically suspected or guide therapy, potentially limiting pelvic MRI to patients needing surgical planning. As such, our primary purpose for this study was to determine if MR enterography can accurately detect perianal disease in pediatric inflammatory bowel disease, confirming or excluding perianal fistulae and perianal abscesses. Our secondary purpose was to determine if MR enterography can distinguish between perianal fistulae and perianal abscesses, assessing prognostic features such as fistula length and perianal abscess volume referenced against pelvic MRI. This is a retrospective study, institutional review board approved, and waiver for individual patient consent was obtained. The included patients were those 18 years or younger with suspected or proven inflammatory bowel disease with pelvic MRI and MR enterography performed within 6 months during the period of October 2010 and March 2013 at a tertiary pediatric hospital. Patients were excluded if surgical intervention or change in medical therapy occurred between the MR enterography and pelvic MRI, 1.5 Tesla scanners or a 3 Tesla scanner, as well if clinical follow-up occurred outside of our centre. Pelvic MRI protocol included the clinical data was obtained from electronic medical imaging, review, coronal short tau inversion recovery, demographics, axial T1 FSE, disease activity, coronal and axial postcontrast history at the clinic visit closest to MR enterography, and in a variable number of patients, axial diffusion-weighted imaging. IBD classification was the MR enterography protocol includes coronal, balanced, steady-state clinical, biochemical, endoscopic, and histopathological data. Coronal and axial fracture clinical diagnosis of perianal disease, axial steady-state deposition, coronal ultrafast 3D, all pelvic MRI and MR scans, or axial diffusion-weighted imaging, the severity of post-contrast review, independent coronal and axial global ST1 imaging pediatric radiology fellow reader 2. Each with 15 and 9 years and 5 and 3 years respective experience reading pelvic MRI and MR enterography. The MRI were randomized with all pelvic MRI and all MR enterography evaluated several weeks apart by readers 1 and 2 for inter-reader agreement, blinded to radiology reports and clinical presentation. The reviewers recorded the perianal fistula number, type according to Parkes classification, location and length, and perianal abscess number, location, length and volume. Consensus review by both readers together re-evaluating MRI discrepant in detection or recorded number of perianal fistulae and abscesses was undertaken, and this consensus data was used for further analysis. Data for each MR enterography was compared with pelvic MRI closest in time with an additional sensitivity analysis on a subset of patients having imaging within 6 weeks, and from this we generated sensitivities, specificities, positive and negative predictive values. Inter- and intra-reader reliability was assessed using CAVA statistics. Current reference standard for determining clinically important perianal disease is the presence of disease on examination. As such, sensitivity analysis used clinical disease as the gold standard, calculated separately for pelvic MRI and MR enterography. Table 1 summarizes patient demographics, clinical findings and endoscopy. 77 patients met the inclusion criteria, with a median age of 14.1 years ranging from just over 5 to just under 18 years. 65% were male and 35% female. Disease was most frequently in the ileocolonic region in 64% of patients. At the time of clinic review, 64% of patients were on antibiotics and 39% on anti-TNF or anti-tissue features for therapy, less frequently methotrexate, true positive and false negative rarely and as a therapy. There was little difference in the imaging
At the
characteristics
time of
for
clinical
fistulae,
review,
however, there was a
global
difference in mean
assessment revealed
volume, moderate
for
abscesses,
abscesses,
true positive
in 45% of
having a volume of
patients,
2.3
mild in
mils
32%
versus false
of
negative
patients,
0.1 mil,
and severe disease in 14% of
MRE
patients.
interreader agreement was
7
moderate for
patients and
perianal
9%
disease,
had no disease.
fair when selecting perianal
Perianal
fistulae
discharge
and
and
perianal
pain were the
abscesses
most frequent
specifically.
symptoms, and skin tags
For
and fistulae
qualitative
the most
assessment
common
of the sequence
examination
parameters
findings.
on MR enterography, post-contrast imaging
When
was
looking at the
considered
overall
best
cohort
for evaluating fistulae and abscesses.
perianal disease
On
was
pelvic
present in
MRI,
73
T2-weighted
patients,
imaging was
fistulae
considered
in
best for
63
detecting
patients, and
perianal
abscesses
abscesses
in
and
31,
post-contrast imaging
using pelvic
preferred for
MRI as the
perianal
reference
abscesses.
standard.
The mean time interval between pelvic MRI and MR enterography was 43 days, decreasing to 15.9 days in the subset cohort of less than 6 weeks. This is an example of perianal
enterography
disease.
reveals sensitivity,
17-year-old male with
specificity,
Crohn's
positive and
disease.
negative predictive
MR
values
enterography was performed
in
at
the 77
1.5
patients as
Tesla and
follows.
revealed a perianal abscess
For
at 8
perianal
o'clock,
disease,
seen as bright signal
the
on
sensitivity is
T2, image A,
82%,
and with room
specificity
post-contrast
100%,
image C,
positive
with
predictive
a
value
transenteric
100%,
fistula
and negative
at
predictive
6
value
o'clock,
23%.
bright on
For detecting
T2, image
perianal
B,
fistulae, this is
with
71%
enhancement, image D.
in sensitivity, 71% in specificity,
Moving on to the clinical
92%
component
in
of the
positive
study,
predictive value,
the mean
and
time interval
38%
between
in
MR
negative predictive
enterography and
value.
clinic visit was 42
For
days,
perianal
with a
abscess
maximum of
detection,
126
the sensitivity
days.
is 51%,
MR
specificity
enterography detection of
85%,
clinical disease
positive
had a
predictive value
sensitivity of
69%,
82%
and negative
and low
predictive value
specificity of
72%.
22%.
There were similar
Pelvic
numbers when
MRI
looking at
detection
the
of clinical
subset of
disease had a
patients,
sensitivity of
45 in the
96%,
whole,
but a very low
who
specificity
had
of 8%.
imaging within less than 6 weeks.
MR enterography has high sensitivity and specificity for detecting perianal disease in our study, indicating it performs well as a screening tool. But as the negative predictive value is low, it cannot completely exclude perianal disease. MR enterography has moderate sensitivity and specificity for perianal fistula detection. Length not a contributing factor for false negatives, although intersphincteric fistulae were more likely to be missed than transsphincteric fistulae on MR enterography. MR enterography has moderate sensitivity and high specificity for perianal abscess detection with a high negative predictive value. Our study had its limitations, the main one being selection bias introduced by the study design. Had a smaller mean volume compared with the true positive in our group were more likely to have perianal disease, as the pelvic MRIs were most often performed for clinically suspected or proven perianal disease, respond equally well to medical or surgical
giving
treatment,
artificially high
suggesting
prevalence of
MR
perianal
enterography may be
disease of
sufficient to exclude
95%,
abscesses requiring
impacting upon our
surgery.
positive and negative predictive values.
MR enterography has
Although
low
medical and
specificity
surgical
for
treatment
detecting
changes
clinical disease,
were eliminated
not
from our
unexpected,
cohort,
the
the
variable
MRI
time
able to
between the
detect
two
early
studies may be
subclinical disease
still
in tracts
associated
not
with
reaching the skin,
therapy-related response,
regardless of severity, giving rise to
with
a
MR
high
enterography
clinical
having
false
high
positive
sensitivity
rate.
and specificity for perianal disease detection. The clinical significance or importance in asymptomatic patients is still unclear. There is increasing data on a distinct phenotype with fistulizing Crohn's disease with a more aggressive luminal course, necessitating significantly increased dosing for anti-TNF therapy, and this suggests recognizing perianal disease on imaging without active clinical disease is likely to be of benefit. In conclusion, careful interrogation of the perianal region using a standard MR enterography protocol without additional sequences can successfully detect perianal disease. This may be sufficient to guide medical therapy, limiting pelvic MRI to patients requiring preoperative planning. As MR enterography negative for perianal disease may miss some perianal fistulae and small perianal abscesses, pelvic MRI is still justified in symptomatic pediatric IBD patients. Asymptomatic patients with MR enterography positive for perianal disease warrants further prospective evaluation to assess the natural history and determine the clinical significance, as these preliminary data suggest MRI has greater sensitivity detecting perianal disease than clinical evaluation alone. Thank you.